Good afternoon, everyone. Welcome to this regularly presented webinar, which is prepared every 6 weeks by St. Paul Institute for Reproductive Health and Rights. Today, we have yet another interesting topic on pregnancy termination in patients with placenta previa and placenta accreta spectrum. First, I would like to introduce myself. My name is Gannet Gabramajan. I work in St. Paul Hospital, Millennium Medical College. I am an obstetrician and gynecologist and also a urogynecologist. Today, here we have Dr. Polyphil with us to brief us on the termination of pregnancy in patients with placenta previa and placenta accreta spectrum. Dr. Polyphil is an obstetrician and gynecologist. He's also a family planning and reproductive health fellow here in St. Paul. He's also an MSc student in sexual reproductive health policy and program in London School of Hygiene and Tropical Medicine. He's a lecturer at the University of Rwanda. He's also an adjunct faculty in the global women's health at the University of Utah, United States, and he has participated in the development of the Rwandan family planning guideline and also clinical guideline for obstetrics and gynecology department. Dr. Polyphil has also published in peer-reviewed journals, both nationally and internationally, and we are privileged to have him with us to brief us on the topics I have already mentioned. Dr. Polyphil, you may take the stage.
Thank you, Dr. Gannett, for the kind introduction. Good morning, good afternoon, good evening, everyone. As introduced, we are going to discuss abortion care services among patients with pregnancy complicated with placenta previa and placenta accreta spectrum. I will take you through the introduction of this content, and we shall discuss the placenta previa and placenta accreta spectrum, the existing need for termination of pregnancy, if any, and abortion specific to placenta previa and placenta accreta spectrum itself. And I should take an opportunity to introduce our practice, and then we shall have some take-home messages. Finally, we shall wrap up our session with a series of questions and answers from the audience. I have nothing to disclose. Please feel free to take screenshots or visit SPEAR website to download this recording. Whether the abortion process was a result of human activity brings up the categorization into spontaneous abortion and induced abortion. Spontaneous abortion are those abortions that occur without intent to abort, and they complicate over 20% of all pregnancies worldwide, and these numbers can be even higher in the developing world. Induced abortion, on the other hand, are due to the human intention to abort or to remove the product of conception. The majority are due to unintended pregnancies. The World Health Organization reports that nearly 30% of all pregnancies result into induced abortion, and 61% of unintended pregnancies end into induced abortion. However, a number of intended pregnancies end with induced abortion, either by error, malpractice, or a life-saving indication, such as atypical eclampsia below 20 weeks or cardiac malfunction, and so on. Induced abortion can be categorized as safe or unsafe. According to the World Health Organization, abortion is safe when carried out using a method recommended by WHO by someone with the necessary skills and appropriate the pregnancy duration. This definition is purely biomedical, and some activists have challenged it by suggestion that it should include a psychosocial component. That means if the definition is accepted, the future definition for safe abortion will include also component of confidentiality. That said, if you carry out a safe abortion to someone, whatever high skills that you have provided, but if you don't keep it confidential, it will still be categorized as unsafe abortion. This is because women have died from breach of confidentiality, or they did not utilize the abortion care services on their subsequent abortion because of their experience for breach of confidentiality on their first abortion experience. Some gaps have been identified. For example, in the recent WHO guideline 2022, the lack of access to safe, timely, affordable, and respectful abortion care has been identified as one critical public health and human rights issue. And also, the guideline, if you go through the whole guideline, you will realize that not every clinical pregnancy is detailed in the WHO guidelines, which some of them include our topic for today: placenta previa and placenta accreta spectrum. Allow me to remind that placenta previa is defined when the placenta is covering the internals of the cervix, blocking the pathway through which the normal delivery process should occur. In unlucky circumstances, when the placenta invades beyond the endometrial layer, reaching the Nitabax layer, the placenta will be called placenta accreta, and the resulting consequences typically can be either the placenta will go just beyond the Nitabax layer but don't go throughout the myometrium, or it can go throughout the whole myometrium, or it can even go beyond the uterus. That give us the definitions of accreta, increta, and precreta, all of which fall into our new definition, or our broad umbrella terminology of placenta accreta spectrum, previously known as morbidly adherent placenta. The current estimate of placenta previa is 1 in every 1,000 births, and it is much higher, almost close to 2%, and at 20 weeks, and this depends on the researchers' view, cross-sectioning at around 20 weeks, and of course, the number of pregnancies with placenta previa at this gestational age would be high, because basically the process of placenta migration toward the fundal portion is not yet complete at the gestational age. And some risk factors include prior uterine surgeries, advanced maternal age, multiparity, prior cesarean deliveries, recurrent abortions, and history of placenta. Let's have a look at the current abortion demand. In Ethiopia itself, in the year 2014, the national estimate of induced abortion was over 620,000 abortions in the year, with an annual abortion rate reaching 28 per 1,000 reproductive age women. From the year 2008 to 2014, there has been estimated 38% of pregnancies that were unintended, and there was a slight decline between 2008 to 2014, and the abortion occurring in facility rose from 27% and doubled to 53%. But still, over close to 300,000 abortions still occur outside the health facilities, and the number of women receiving treatment for complications for induced abortion has also doubled from 52,000 to over 103,000. These numbers represent individuals. They represent the human, the women, our mothers or sisters, and they represent a great need for safe abortion services expansion all over the country of Ethiopia, and also not only in Ethiopia but also anywhere else that the abortion care services are limited or poorly accessible. So if we go back to again to our case of today, placenta previa and placenta accreta, and look at the risk factors that the women have and the safe abortion indications. So I will be asking questions and you can answer. Can a woman with prior uterine surgery have a risk factor? Is it a risk factor for placenta previa? Yes, all these are risk factors. But then, can a woman with prior uterine surgery meet a maternal health indication for abortion? The answer is yes. A woman with pre-uterine surgery can have cardiac morbidities that require termination of pregnancy, can have uh, eclampsia, atypical, be below the viability age that may need abortion, and that's one typical. Can she be raped? Well, we don't wish her to be raped, and all countries are on the road to fight against rape, but we know we haven't eradicated rape yet. So every woman currently is still at risk of being raped. So, can she have any pregnancy as a result of an incest? The answer is yes. She has relatives. And can she be aged less than 18 years of age? The answer is yes, depending on when she had an indication for a uterine surgery. Um, can she have a fetus with congenital anomaly? The answer again is yes. And can she have a physical or mental deficiency that make her a candidate for uh, safe abortion in case she wants it? As you can see, all these indications for legal abortions in Ethiopia can fall in a woman with prior uterine surgery, which basically means can fall in a woman with a risk factor for placenta previa, or who has actually a placenta previa. And each of these risk factors for placenta previa will at once interfere or come to meet one of the definition for legal safe abortion in Ethiopia, and therefore a need for ourselves to secure our skills, our knowledge, and our settings to provide safe abortion care services, even among women with placenta previa or placenta accreta syndrome. However, the termination of pregnancy complicated by placenta previa or placenta accreta spectrum is not easy. The placenta previa itself imposes a dilemma on the passageway for for the product of conception to be evacuated. And unfortunately, we have insufficient literature regarding the abortion in placenta previa, placenta accreta spectrum, even in the most famous journals or the well-known OBGYN associations or organizations. We don't have systematic review that have evaluated the service care for termination of pregnancy in pregnancy complicated with placenta previa or placenta accreta spectrum. However, we have some studies that have been published based on case series, retrospective studies, and they have generated some institutional guidelines. In this study conducted in Wuhan city in China, it was observed 34 women with placenta previa and compared with 227 control women without placenta previa. The intervention here was medical abortion using mifepristone plus misoprostol or ethacridine lactates, which is a routine care of medical abortion in China. And at the end, the results showed the feasibility of medical abortion in the observed cases, the 34 observed cases with placenta previa, and overall rates of prenatal hemorrhage, postpartum hemorrhage, and prepubertal morbidity, emergency uterine artery embolization, and ICU rates were higher in the observed cases, but there was no significant statistical differences. And as conclusion, I quote the author: the combined therapy of mifepristone and misoprostol or ethacridine lactate was useful for termination of mid-trimester pregnancy with placenta previa, and attention needs to be attached to prenatal hemorrhage during labor induction. In this study conducted in Japan in 2007 among 158 women that had pregnancy termination between 12 to 20 weeks of gestational age, only 7 of them had placenta previa, and they still managed to divide them into 2 different groups, and 4 of them underwent dilatation and evacuation, and 3 had a medication abortion with gemiprost. The remaining 151 without placenta previa had gemiprost termination. The study showed that there was no difference in blood loss among the 3 groups, and one placenta previa with gemiprost termination required transfusion. And the author concluded that the use of gemiprost for second trimester pregnancy termination in women with placenta previa appeared to be relatively safe and does not increase intraoperative blood loss in the majority of cases. And note that they had only 7 cases of placenta previa. Looking on data in the United States, there's this study that was conducted in 1994 in New York among 131 women who attended for elective termination of pregnancy between 13 to 24 weeks of gestation. 23 of these women had placenta previa, and after all, there was no significant difference in operative time and time to discharge, infection, need for transfusion, and hysterectomy between women who had placenta previa and women who did not have a placenta previa. And the conclusion from the researchers, based on their experience and the data that they recruited from these 31 elective women, is that the second trimester pregnancy terminations in the presence of placenta previa are associated with a higher estimated blood loss, but no apparent increase in abortion-related infection, postoperative transfusion requirements, hysterectomy, or other complications. When it comes to termination of pregnancy complicated by placenta accreta spectrum, the literature becomes even much rarer. The study conducted in China among 29 women with placenta accreta spectrum that were dated 19 to 24 weeks of gestational age. Among them, 7 had hysterectomy and 22 had medication abortion. Among those who had hysterectomy as mode of termination of pregnancy, 3 had hysterectomies as management of complications, and the 4 that are remaining underwent hysterectomy alone without removal of the placenta. Either the placenta was removed partially or was kept all of it in situ. Among the 22 who had medication abortion, all of them had the placenta remaining in situ, partially or fully. That gives a total of 26 placenta that were kept in situ, either partially or in situ. And at the end, all women managed to expose the placenta through the vaginal route between 19 to 190 days, and all uteri of the 26 women were preserved, and eventually 7 of them had spontaneous pregnancies. According to this, the author conclude that leaving the implanted placenta in situ is the preferred choice for patients with placenta accreta spectrum. Having a further look among women undergoing second trimester abortion complicated by placenta accreta, in California they conducted a study between 2000 and 2007, and only 7 women were recruited having placenta accreta. All these women underwent dilatation and evacuation, and the placenta was removed at the time of D&E. And 3 of them were successfully treated with uterine artery embolization, and 4 of them who were not treated with uterine artery embolization eventually had hysterectomy, and that led to the conclusion that uterine artery embolization is an alternative to hysterectomy in patients with post-abortion hemorrhage refractory to conservative measures. Back in China again, a study was conducted to compare women who had placenta previa with accreta versus women with placenta previa alone. And this was 25 cases, and that were divided into 2 groups, 12 in the accreta group and 13 in the previa alone group. and they realize lower vaginal delivery rates in the accreta group, longer mean hospital stays, and longer interval from intramniotic tacrolimus lactate to delivery, and considerably more blood loss in the group of placenta previa with accreta compared to the previa alone. And the conclusions from the researchers were that the vaginal delivery is recommended for patients complicated with complete placenta previa who undergo therapeutic abortion in the second or third trimester. However, he added, when placenta accreta is present, doctors should consider hysterectomy, abortion, or curettage after preventing uterine artery embolization. All these studies, they highlight uh, a lack or a scarce or a knowledge gap in the existing literature. As you can see, there is no even one single study that had uh, at least 30 clients with placenta previa or placenta accreta, and therefore each institution generates their guidelines based on their patients' experience and also their clinical experience. If you travel or browse in the American College of OBGYN, even there is also no clear recommendation about what to do. Even with the Royal College of Obstetricians and Gynecologists, even in the Canadian College, there is really lack of data in this practice. However, it doesn't mean that we will not have patients. The patients will come anyway. And therefore, I would like to share our experience at Simple Hospital Millennium Medical College. Our experience and our practice, if a pregnancy is dated below 20 weeks, what we do, we offer both medical and surgical abortion to the woman. And again, it depends on the circumstances. Let's say she has a pregnancy dated 16 weeks and she has also anemia. So in that case, the anemia drives us to offering to preferring a surgical method over the medical abortion. If a pregnancy is dated between 20 to 24 weeks, we offer dilatation and evacuation similar to other pregnancies that do not have placenta previa. And between 24 to 26 weeks, we offer both dilatation and evacuation and hysterectomy as options. That means we can do DNE or we can do a cesarean delivery. However, for pregnancies that are dated after 26 weeks, our recommendation in our practice is hysterectomy. We prepare the cervix on day one using laminaria or dilapan, depending on the gestational age, and we give it concomitantly with mifepristone, and the patient spends overnight in the hospital as compared to the other women to whom we give laminaria and they go home and they would come the following day. The dilatation on the day of DNE, if additional dilatation is needed at the time of DNE, usually we use Hager or Pratt dilators to reach the desired opening of the cervix, and we offer routine pain management using diclofenac or ibuprofen or combined 1 hour prior to dilatation and evacuation, and we also offer paracervical block using lidocaine 20 milliliter, 1% of lidocaine 20 milliliter. And evacuation is done using similar technique to other non-previa patients, using sulfur-augmental forceps depending on what is available. And as take-home message, abortion among pregnancies complicated by placenta accreta spectrum can be really, really challenging, and each woman should be individualized for individual risk factors for complications. And second trimester termination of pregnancy should be conducted in hospital in those women with placenta previa. And strategies to expand the utilization of family planning should be always emphasized to prevent the need for termination of pregnancy. It is very, very important to know that in most cases, women have a termination of pregnancy because initially this pregnancy was not intended, was not wanted, and therefore it's our responsibilities as healthcare providers to ensure that women have access to family planning, effective contraception, so that they don't fall into a category when they will need termination of pregnancy, when they will need abortion. However, equal efforts should be put in place to avail safe abortion services for women in need. I will close with this message from the Royal College of Obstetricians and Gynecology Best Practice, published in 2022. They say there are several myths about the consequences of abortion. Individuals who experience concerns can be reassured that there are no proven associations between having an abortion and subsequent ectopic pregnancy, placenta previa, infertility, breast cancer, or mental health problems. Thank you very much for your kind attention. The floor is open for questions, comments, and discussion.
Thank you, Dr. Polyphil. It was an interesting presentation, well summarized and timely. Now the floor is open for questions and discussions. If you have questions, you may put them on the Q&A, or you can also raise your hands. And if you want to talk, we can allow you to talk by raising your hands. So until other questions are coming, I have one on the Q&A panel. So what are the management options of patients with cardiac disease and placenta previa and placenta accreta spectrum on whom you want to terminate pregnancy?
Thank you very much. This is a very nice question. Both conditions, the placenta previa and the cardiac issues, are both high-risk conditions, and each of them actually requires a special attention of the clinician. The termination of pregnancy among these women, we usually don't want the women with cardiac conditions to suffer a lot from the pain, and therefore we maximize our effort to reduce the time during which they will have pain, and therefore a surgical option is preferable because it can be controlled within a short time or period, and also the bleeding can be controlled. However, it's very important to emphasize the collaboration and the teamwork with the anesthesia team in case another emergency or in emergency cardiac intervention or cardiac supports can be needed. Thank you very much.
Thank you, Dr. Polyphil. I see one hand raised. Sentayo Tareke, you may speak. Can you hear me, Sentayo?
Yes, I can hear. Is it the same with the diabetic mellitus? The management, is it the same with diabetes mellitus patients?
Yes. The patient with the diabetes mellitus also can have similar pregnancy termination.
Yeah.
Okay.
Yeah, I don't know if you got my answer. So the client with diabetes mellitus also can have a similar regimen for pregnancy termination.
Thank you. I got it.
Yeah, both.
Okay, thank you, Sentayo and Dr. Polyphil. I have another question here. Dr. Poly, do you have any experience of managing such cases at St. Paul Hospital? And can you share us this experience if you have any?
Yeah, thank you very much. When we are discussing termination of pregnancy among women with placenta previa, this question almost always comes to our table to share our experience. St. Paul Hospital Millennium Medical College, having the Fellowship of Family Planning and Reproductive Health, we tend to receive most complicated cases that require complex abortion care services. And I think this attracts clients to come from all over the country. And yes, we've had a number of cases of women who came with placenta previa and some of them with placenta accreta. And some of them, we manage them with medical management, and some of them, we manage them with surgical management. And we actually offer laminaria or dilapan according to what is available. And we usually have, we've never had any woman who needed special care due to complication such as the need for ICU. All the women we had in our experience were all managed and they were discharged within the same day. Thank you.
Okay. Thank you, Dr. Polyphil. If you have further questions, I see one hand raised. Abdul Hakim, can you hear me? And you can't speak. Abdul Hakim.
Hello, can you hear me?
Yes, we can hear you, Abdul.
Okay, I have one question that is if a patient have previously valve surgery, for example, if she have any metallic prostate valve and she was on anticoagulant and she presented with a placenta previa for termination, how we proceed in such case if it is known that if the patient have metallic prostate valve, she is on anticoagulant and she have placenta previa, how we proceed with termination of pregnancy in such kind of patients?
Thank you very much. This is another one good question, actually. This is, first of all, this is one of the most challenging clients. But the thing is, the current evidence supports that with women who need abortion care services and who have other risk factors for bleeding, a surgical approach should be emphasized. And that's what we do in our practice, and even the current recommendation from the American College of OBGYN and the Royal College of OBGYN, they also recommend the same. So for this client who is on anticoagulant, who has a prosthetic valve, the approach is to offer her surgical termination of pregnancy, because a surgeon or whoever is providing the service, he will be able to control the hemorrhage, which is different from if we give medical management and she has a hemorrhage, we cannot control it and we cannot quantify or how long or how much she can bleed. And we don't know when she can bleed too much. While with surgical abortion, we know exactly when we are starting the surgery, the intervention, and we know when we are finishing it, and therefore we can clearly control the bleeding. So even if she has severe thrombocytopenia and she needs a surgical, she needs abortion, she qualifies for a self-termination of pregnancy. And therefore, what we need, we put in place other settings that are required to save her. Let's say she has severe thrombocytopenia of only 6,000. In that case, that client, if she needs a termination of pregnancy now or tomorrow, it's very good to secure platelets or other together with other coagulants and even blood products in case they are needed. In our experience, what we've had with women with thrombocytopenia or women on anticoagulant, what we do is we secure, we order or we book blood for transfusion and even platelets, and we go for the surgery. And among the women whom we have provided the services, usually the need for transfusion hasn't been very much observed. Instead, their time to discharge increases because we want to observe them for more than 1 hour or 2 hours compared to what we do with the general population. Thank you.
Thank you, Dr. Poli. So Dr. Daraje has raised his hands. and also Dr. Zarihun Bayena. Both of you can speak first, Dr. Daraje.
Can you hear me?
Yes, we can hear you, Dr. Daraje.
Okay. Thank you, Dr. Poli, for your very nice presentation. My question is, in cases of the study conducted in China, where they have left the placenta in situ, did they use drugs like methotrexate in decreasing the size of the placenta for subsequent, to decrease the chance of infection and the possibility of productive years or reproductively active years after this management? Because if we leave the placenta in situ, the practice is just to try to decrease the size of the placenta. One of the ways is by administration of methotrexate. So was there any use of such drugs? Thank you.
Thank you. You got the question?
Yes, yes.
Okay, good. Dr. Zarihun, can you speak?
Hello.
Hello?
Can you hear me?
Yes. Yes, Zarihun, go ahead.
Okay, thank you very much for such a well summarized presentation. So I have two questions. The first one, do you have any recommendation or minimum requirement based on the setups to perform second trimester abortion with placenta previa? Because I'm working like in the setup with only specialty clinic, one of the affiliate of the SPIR, actually. And the other one is there any different opinion for management of patient with placenta previa based on the type of the placenta previa? Thank you.
Thank you. We may respond to this one and we'll continue.
Okay. Thank you very much. Starting with the first question about the study in China. Yes, you're correct. Those women who had the placenta accreta and increta, actually, when the placenta was left in situ partially or completely, the care providers provide them with methotrexate. However, this practice has been later challenged that it was not necessary to provide this drug, given the possibility of other complications that would have arisen, and it's not routinely advised in this case, but to this particular population in China, they gave methotrexate. I don't think if this answers to your question. If it was whether they were given methotrexate, yes, they were given methotrexate, but this was later challenged when the paper was presented to international reviewers. And the other question was if there are special setups that are required in case of placenta previa or accreta that require second trimester abortion. Yes, as we mentioned in our practice, usually, for example, when we give laminaria, we don't ask the woman to spend overnight. We give laminaria today, and tomorrow she comes for D&E, and after D&E, after 1 hour or 2 hours, she goes home. But with women with placenta previa, we do a little bit different. We don't routinely offer them an outpatient management to go with a laminaria at home, because anything can happen at any time. So far, we haven't observed women who spend overnight and bleed overnight here, but we still keep that sense, that spirit of security, given that there is not enough data that has been conducted among this particular population group. So we would advise that for the setup, they should be a well-trained healthcare provider in the insertion of laminaria itself, and also in the setup that where, in case she would bleed due to the laminaria itself or the process of laminaria opening the cervix due to its hygroscopic increasing size. So if that brings up a hemorrhage or bleeding, we recommend that there should be a setup where a woman can immediately have an intervention, either an immediate DNE, or in case required for surgery or hysterectomy, we recommend that there should be a setup that has that. Or if the setup is not available, a woman should be referred to centers where this is possible. So the material for DNE definitely should be always available. To be able to open the cervix, to be able to evacuate the content, and an MVA to assure completeness. Thank you very much. I don't know if I don't remember what the second question I was asked. Remember, or
No.
you can repeat the second question if you have lost it.
Yeah, Zarifan.
Yes. Did you hear me? Can you hear me?
Yes, Zarifan, we can hear you.
Yeah, the
Sorry,
second
we lost your
question-
question.
Okay, the second question, is there any different recommendation based on the types of the placenta previa?
Yes, the type of
Or it
placenta,
is
yeah.
similar with the whole types of placenta previa? Your recommendation.
Thank you. Good question. So there is no different recommendation. And again, there is no enough data that would generate a different recommendation. All the data that are available are based on retrospective studies. And most of those retrospective studies had only documented placenta previa without categorizing it, whether it is partial or complete. But according to data that we know at TAM, so the placenta previa, I think the existence of previa itself should drive the decision rather than categorizing it within partial or incomplete, which is opposite to the recommendations before 2012 that used to give different management options. So there is no current data that would suggest a different management plan between placenta previa, complete or incomplete, or even between placenta accreta, or precreta. So there is no enough data. I couldn't find any data that's or any paper or any case report about placenta precreta that required termination of pregnancy, and therefore it's very difficult to make a conclusion about it. Thank you.
Okay. Thank you, Dr. Polyphil. We have 3 more questions from Drs. Damsash, Al-Bacho, and Al-Farid. So Dr. Damsash is asking, what is your comment on the double setup DND in the OR for suspected PAS to avoid hysterectomy or even hysterectomy? And the second one is, in a resource-limited area, how can we identify placenta previa from placenta accreta is the second question from Alapacho. And Alfred has asked, in which patients do we consider uterine curettage for retained placental tissues in patients with placenta accreta syndrome spectrum, and what is the basis for the guidelines of pregnancy termination in patients with placenta previa and placenta accreta spectrum? What is the level of evidence, and do we have any local study on this?
Thank you. Those are very nice questions. Starting with Demsash, please, I apologize if I don't know how to call.
You said it correctly.
Okay, Demsash. The double setup has been documented and has been discussed in some of the studies that we discussed, like the study that was conducted in New York. The double setup where a woman is prepared for possibility of emergency surgery, and also the second setup where the operating theater is prepared for emergency reception of a client. So I would strongly recommend that where possible, that the double setup should be always enhanced. At least for women in our practice, for women who have placenta accreta spectrum, we always prepare the double setup. Either we conduct the intervention, the DNE, within the OR. We do exactly what we do for other women who do not require intervention in OR. We give a paracervical block, we do dilatation using the regular dilators, and we evacuate the uterus. But the anesthesia is there, the anesthetist is there. They are doing nothing until we can observe that we need an emergency intervention, and then they can intervene. So we have that in our practice, even though we haven't felt into a need for it, but that's our practice. We take them to OR and we perform the procedure in OR. The recommended practice to differentiate placenta previa and placenta accreta, well, the placenta previa can be easily diagnosed with ultrasound by basically primarily the transvaginal ultrasound. So, but it may be a little difficult to differentiate to affirm if it has accreta or if it doesn't have accreta. The ultrasound features remain the lack of the uteroplacental cleavage line, or having the vessels using Doppler ultrasound, looking at the vessels that are passing, if they are parallel with the uteroplacental cleavage line, if any exists. But the definitive diagnosis plan for placenta accreta or increta or precreta is the use of the MRI if available. So unfortunately, in many situations, there is no accessible immediate MRI, and therefore you may want to rely on the observation that you are seeing on ultrasound. Patients for whom we would consider uterine curettage for retained placenta tissues in patients with the placenta accreta spectrum. So the current study that was conducted in China, that's compared those with accreta and those without accreta. They both had previa. One had increta and the other did not have increta. So they did not recommend to do a curettage. So the current evidence is to individualize by case, and plus the curettage is no longer it is now discouraged by the new WHO guideline of 2022. If you can't easily remove the placenta, or if you suspect there's a placenta accreta spectrum, it's better to utilize other available resources, the colleagues, or transfer to treatment to higher centers, or leave the placenta in situ. Don't fight with it. If she has active bleeding that can immediately kill the client, you can do a life-saving intervention to control the damage. But if there is no emergency need for hysterectomy or hysterectomy, you can always contact other institutions for referral. So otherwise, the curettage for women with placenta increta or accreta is questionable, and you may not know which part of the uterus you are curating, or you may not even know which part needs the curate. So the basis for guidance for pregnancy termination in patients with placenta previa and placenta accreta syndrome, there is discussing the level of evidence also. Not every article, I think not every article goes through the discussion of level of evidence. If it was just a case report that was of 7, I don't think we can consider passing it through the level of evidence, because it was just a report that was conducted, that was reported to the audience and to the public, and the level of evidence, unless we are saying that they lied to us, because there were no enough inferential statistics or randomized trial or controlled techniques to see what is best versus the other. So we have poor data, so it's difficult to estimate the level of evidence given that the statistical methods that were used were only based on few number, and the current local studies that were conducted, I believe some exist, but were not availed to the access from the sources that I have checked. Thank you very much.
Thank you, Dr. Polfil, and also the participants for such interesting questions. Dr. Daraja, you have raised your hand again. You may speak.
Thank you, Dr. Gannet. My question is for Dr. Poli. Do you have any practice of abortion care general, and then that of managing such case as placenta previa or placenta accreta syndrome in the future? I mean, this may apply generally as your center is a center of excellence, family planning and abortion care or RH. What's your recommendation to conduct such study and share the experience?
Dr. Dereche, we are very sorry. We apologize. There came some interferences, and we couldn't catch well your question. And we kindly ask you to repeat it if possible.
Dr. Daraja, there were interruptions. We couldn't hear
All
you
right.
totally.
Okay. Can you hear me now? Can you hear me now?
Yes.
All right. My question was, what's your recommendation in line with generation of evidence in cases of placenta previa, placenta accreta syndrome, and management of abortion, or generally speaking, in generation of evidence of the experience at St. Paul regarding the abortion, the safe abortion service? So what would be your recommendation in the future? Thank you.
Thank you very much. I think it's a very good point, actually. There is a need to generate evidence to the management of women with placenta previa and accreta spectrum. So this is a very good point, and it's a learning point. So from the number one issue is that the condition itself is rare, is generally rare in the community. So, and therefore having enough number that can generate a good evidence, it may take time, but we can still, based on what we have seen and what are coming in the future, and maybe generate a registry for placenta accreta, placenta increta, and learn from that. I think it's a very good point you're raising, Dr. Dereche, and we should learn from that and generate a sort of registry that in the future we can look at and generate some evidence. I really appreciate that input, and we can take it as a good point to learn from. Thank you.
Thank you, Dr. Polife. There are no more hands raised and no more questions in the Q&A panel. If you have burning questions, I may give for some participants. If not, I will ask one question. In advanced second trimester cases, would there be a difference in the way we are preparing the cervix in patients with such placenta previa and placenta accreta spectra?
Thank you. Good question. So still in advanced gestational age, as we shared our clinical practice, so we offer D&E for in case of placenta previa, we offer D&E up to actually 26 weeks. Mm-hmm. And there are two options in that case, either a D&E or hysterectomy for this client. So in case of D&E, the gestational, we offer laminaria for dilepan, and the number and the size of laminaria will depend on the gestational age. As our standard is, we take the gestational age and we consider it to calculate the number of the laminaria based on the number of the dilatation size, the diameter that we want to have. And I think that's what makes the big difference. And also prepare the setup, and also Never forget to prepare the woman psychologically, morally, in the situation. First of all, it's a very critical situation for the healthcare providers, and we want also the woman to not see us stressed in a stress mode, because it may make her lose trust that she will survive. Instead, we want to always reassure her, especially when it comes to the advanced gestational ages. Thank you very much.
Okay, thank you. So if there are no more questions on both platforms, I think it's time to wind up this session. Thank you, Dr. Polifour, for your excellent presentation and also discussions, and also the participants for active participation. I think it's an interesting, rare but a difficult obstetric situation where we should be stand by for hemorrhage and further complications for the patient. And the key message is, if the woman has such a problem and you don't feel like you can manage such patients, it's better to refer them to best setups where different options of management can be offered. With this, if the other panelists have no more points to say, we will wind up our session. Thank you so much for having you here, and we hope to see you in 6 weeks' time with another topic and on this platform. Have a great evening, everybody.
Thank you very much.
Thank you.